Hello, my name is Dawn Harding and I'm the clinical nurse educator attached to both Cheltenham and Gloucester department. My aim for the future is to work in collaboration with the wards that are attached to us, Knightsbridge being one of those wards. And I was invited to give a presentation about what happens in the endoscopy environment, but unfortunately I'm not there in person, so thereby you have this video. So generally the objective this morning is to give you an overview of the endoscopy department, explain a bit about patient preparation. I'm going to talk a bit about the procedures that are conducted in endoscopy, as well as I'm going to touch a bit on consent. Because the consensus is nurses do not consent, that's a true fact, but there are a few incidences where we do, so I'm going to talk about that and the importance of getting the patients consented by the physician before they actually get to the department. So basically I'm in charge of both Cheltenham and Gloucester. So I go to Gloucester on an ad hoc basis, but I'm mostly based in Cheltenham. Presently I'm in one of our theaters. So behind me you'll see one of the stacks which we use in order to perform the procedure. So there are different things that we use within the department. I would like to say as well, I would like you guys to take this opportunity, as well as the opportunity in the future, to come down to the endoscopy department to see what actually goes on, within the department, learn a bit about the nitty-gritty of what actually takes place here. So to begin with, some of the procedures that are carried out on a daily basis, we do colonoscopies, gastroscopies, flexible sigmoidoscopies, ERCPs, insertion of pegs, removal of pegs as well. That's on the Gloucester side. On the Cheltenham side, sorry. On the Gloucester side, they do bronchoscopies, EBUS, ESUS, in addition to the other procedures that I mentioned, as well as they do thoracoscopies. They also have a special inpatient list. Our department, on the other hand, we do inpatient list, but that's done on our bleed list. We usually do them early in the morning. We try to aim for about 7:30. Well, we get here for 7:30, probably about 8 o'clock. So most times you would have gotten a call either the day prior, depending on the procedure that the patient is going to be coming to the department to have, talking about how to get the patient prepared for that, as well as depending on what happens. Sometimes there's discourse between the nurse on the ward, as well as our coordinator here, because sometimes things do go not to plan. So how are we going to prepare an inpatient for a specific procedure? So let's say, for example, the first thing the nurse does, the coordinator does, she calls the ward. Most times it's prior the day before, and she would liaise with the nurse that is taking care of whichever patient it is that's coming to our department. So the things that we need done, things are getting better, but there's still a far way to go in terms of things really getting better, and because we're trying to decrease the incidence of having patient procedures cancelled or having patients come to the department and a specific thing wasn't done, and we either have to send the patient back to the department, to the ward, to get this thing sorted out, and that procedure is either cancelled. So we're trying to get that to as low or to as minimum as possible, but still things do happen. So as a new nurse or an HCA or a trainee, sometimes you might not encounter this. So the process is the coordinator calls the nurse that is taking care of patient A to come to have, let's say, a colonoscopy. If it's an inpatient colonoscopy, because some persons are outpatient, but they come to the unit, they come to the ward to have their preparation done because they can't do it at home. Some persons might be on the ward and they might have a bleed and they need to have either flexible sigmoidoscopy or a gastroscopy. So there are two things that happens. So it's either an outpatient that can't manage to take their prep at home, that needs to be hospitalized, that comes to the department to have a colonoscopy, or there is that inpatient that suddenly has melena, or they have hematemesis and the blood samples are checked and the HB is low, or other labs are deranged and they suspect that person either has an upper GI bleed or a lower GI bleed, and they need to come to our department to have either gastroscopy or flexible sigmoidoscopy. So those are the two persons that we deal with when it comes to the ward setting. So the preparation process is the patient should or must, I should say must, be consented on the ward before they actually come to the department. Reason being, you guys know this patient better than we do. We don't know, we just know a patient has a bleed, either the HB low, the other lab results are deranged, and they're coming to us to have a gastroscopy or a flexible sigmoidoscopy, but we know nothing else about that patient. You guys know the patient, the doctors on the ward, they know the patient, so they are the ones that are supposed to be consenting those patients before they actually come to our department. So the first thing is consent. You need to run behind them and get that consent signed, because there are many occasions, or a few occasions, the patients come to the unit, they haven't been consented, and it depends on the consultant who is scoping that day. They might say, okay, I'm going to do the consent, but there are some consultants that they draw the line, they say, no, I'm not doing that consent. The patient needs to go back to the ward for the consultant to do the consent, then the patient will come back. So you have a slot wasted and a patient that might need to be scoped, they have the procedure cancelled and they have to return to the ward. So consenting is important. The second thing is you need to complete the pathway. So I have two pathways here. You might have seen me with some paperwork in my hand. So we have an older pathway and we have the newer version of the endoscopy pathways. So inside, most likely, you'll fill the outer bits with the patient demographics. You'll put it here, patient demographics. They're in the hospital, so you will need to fill all of this information in. The nurse just signs across the board, signature, print name, RN, whoever, if it's sister. And then there's an MRSA bit at the bottom here. If the patient is coming for a PEG, there's a section to fill in for PEG insertions. You flip the page to page 2. The nurse fills this information, and most likely, because the patient is coming from the ward, they will come with their notes, the medical notes. They will come with their drug chart as well as the bedside notes. So all of those things need to come with the patient when they're coming to the department. So the nurse just has to fill in a little bit of information, most likely put in the demographics. So this is one thing that needs to be done, the pathway. And then she can fill in, just read here, see what's necessary. If there are other comorbidities, she can put it here where there are medical conditions. There's a section to do a bit of tick box exercise, so she can fill that information in, as well as I said, they come with the drug chart. So don't forget to send the drug chart, because sometimes they do come without the drug chart, and then somebody has to run, collect it, and come back. So drug chart, medical notes, bedside notes, comes with the patient. As I said, the consent form needs to be signed, as well as fill in the pathway. If the patient is coming for an ERCP, there's a special pathway that needs to be filled as well. So this is the ERCP pathway. So it's just fill the information in. Fill the information in. The patient clotting needs to have clotting screening done, as well as if the patient is on anticoagulants, the patient most times would need to have vitamin K, so that would need to be prescribed. We've had incidences where patients came, they didn't have the vitamin K, the clotting screening was deranged, so we had to cancel, and then it was a whole mess. So as I said, when I return, I will visit the ward so you can have a look at the pathways, but you should have the pathways on the ward as well. So consenting needs to be done. You need to fill in the pathway for whichever procedure it is. The patient needs to be cannulated, as well as when the nurse calls, when the coordinator calls to speak to the nurse on the ward, she would ask about mobility, if the patient travels on a bed or if they're ambulatory and they can come in a wheelchair. So those are the key things that needs to be done. The only difference is if the person is coming for an ERCP or a peg insertion or a gastroscopy, anything that has to do with the upper digestive tract, the patient needs to be fasting. So for about 6 hours, but most likely the patient would have been fasting since the day before, because the last meal in the hospital is usually at 6:30. So they would have had a long fast. But remember to put your nail by mouth sign on the bed head, because we've had incidences as well where patients are supposed to be fasting. They fasted throughout the night because they were asleep, and then the nurses gave them breakfast in the morning. So just remember those key things. If it's anything with upper digestive tract, patient needs to be fasting. If it's flexible sigmoidoscopy, prescription will be done for an enema, which will be administered in the ward. And just remember the key things that needs to be done before the patient comes, and I stress consent, pathway,